In this lecture, we'll be discussing anatomy, clinical features of orbital pathology and investigations. Let's start with the anatomy of orbit. The orbit is a pear-shaped cavity, the stalk of which is the optic canal. The roof consists of two bones, the lesser wing of sphenoid and the orbital plate of the frontal bone. It is located subjacent to the anterior cranial fossa and the frontal sinus. A defect in the orbital roof may cause pulsatile proptosis due to transmission of CSF pulsation to the orbit. The lateral wall also consists of two bones, the greater wing of the sphenoid and the zygomatic. The anterior half of the globe is vulnerable to the lateral trauma since it protrudes beyond the lateral orbital margin. The floor consists of three bones, the zygomatic, maxillary, and palatine. The posteromedial portion of the maxillary bone is relatively weak and may be involved in a blowout fracture. The orbital floor also forms the roof of maxillary sinus so that the maxillary carcinoma invading the orbit may displace the globe upwards. The medial wall consists of four bones, maxillary, lacrimal, ethmoid, and sphenoid. The lamina papyracea, which forms the part of the medial wall, is paper thin and perforated by numerous foramina for nerves and blood vessels. Orbital cellulitis is therefore frequently secondary to ethmoidal sinusitis. Now, the superior orbital fissure is a slit linking the cranium and the orbit. A number of important structures pass through it. It is described in the first figure, and there is a picture of it in the second one. So we will discuss each of them. The superior portion contains the lacrimal, frontal, and trochlear nerves, and the superior ophthalmic vein. The inferior portion contains the superior and inferior division of the oculomotor, that is the third cranial nerve, and the sixth, that is the abducens nerve. In addition to that, it contains nasociliary nerves and the sympathetic fibers from the cavernous plexus. Inflammation of the superior orbital fissure and apex, which is Tolosa-Hentz syndrome, may therefore result in multitude of signs, including ophthalmoplegia and venous outflow obstruction. The inferior orbital fissure lies between the greater wing of the sphenoid and maxilla, connecting the orbit to pterygopalatine and infratemporal fossa. Through it runs the maxillary nerve, the zygomatic nerve, and the branches of pterygopalatine ganglion, as well as inferior ophthalmic vein. The sensory supply of orbit also passes through this area. Now, the clinical features in cases of pathology of orbit include, first of all, symptoms. Now, the patients in cases of orbital pathology present with symptoms of eyelid and conjunctival swelling, redness, watering, pain, sometimes on or exacerbated by eye movement, increasing ocular prominence, displacement or a sunken impression of eye, double vision and blurring, and sometimes a pulsing sensation or audible bruit. There is soft tissue involvement on examination, eyelid and periocular edema, skin discoloration, ptosis, chemosis, that is edema of conjunctiva which may involve the plica and caruncle, and epibulbar injection. As we can see in the picture, there is chemosis and injection in the picture here. And causes include thyroid eye disease, orbital inflammatory disease, and obstruction to the venous drainage. One of the most important features is proptosis, which is described as an abnormal protrusion of an organ, but is generally applied to the eyeball. Exophthalmos refers to specifically to the eyeball only. Proptosis may be caused by a retrobulbar lesion or less frequently, a shallow orbit. The intraorbital portion of the optic nerve is longer, which is 25 millimeter. Then the distance between the back of the globe and the optic canal, which is 18 millimeter. This allows for significant forward displacement of the globe, which is proptosis, without excessive stretching of the nerve. Now, it can be asymmetrical, which is readily detected by looking down at the patient from above and behind, as in this picture. You can see you can always examine the patient from behind initially, and it becomes very clear. The direction of proptosis may indicate the likely pathology. For example, a space-occupying lesion within the muscle cone, such as a cavernous hemangioma or optic nerve tumors, cause axial proptosis, whereas extraconal lesions usually give rise to combined proptosis and dystopia, which implies displacement of the globe in the coronal plane, usually due to extraconal orbital mass, such as lacrimal gland tumor. As it can be seen in the picture, there is displacement in the coronal plane. One eye seems lower than the other one. Now, horizontal displacement is measured from the midline, which is nose, to the center of the pupil. While vertical dystopia is read on a vertical scale perpendicular to horizontal rule placed over the bridge of the nose. The mired eye should fixate straight ahead if necessary, facilitating this by occluding the fellow eye. The severity of proptosis can be measured with a plastic ruler resting on the lateral or orbital margin, or with a Lutz exophthalmometer using a similar principle. Commonly, a binocular exophthalmometer, for example Hertel's, as it is shown in the picture, is employed using visualization of the corneal apices to determine the degree of ocular protrusion from a scale. Measurement can be taken both relaxed and with the Valsalva maneuver. Readings greater than 20 millimeter are indicative of proptosis, and a difference of 2 to 3 millimeter or more between the two eyes is suspicious, regardless of absolute value. The dimensions of the palpebral apertures and any leg of ophthalmos should also be noted. Pseudoproptosis, which is the false impression of proptosis, may be due to facial asymmetry, enlargement of globe, for example in cases of high myopia or ophthalmos, lid retraction, or contralateral enophthalmos. Now, coming towards enophthalmos, it implies recession of globe within the orbit. Causes include congenital and traumatic orbital wall abnormalities, atrophy of the orbital contents, for example radiotherapy, scleroderma, chronic eye poking in blind infants, for example in oculodigital sign, or sclerosis, for example metastatic serous carcinoma, sclerosing orbital inflammatory disease. Pseudoenophthalmos may be caused by a small or shrunken eye, as in cases of microphthalmos or phthisis bulbi, by ptosis, or by contralateral proptosis or pseudoproptosis. There are some dynamic properties in different cases. For example, in cases of increased venous pressure by dependent head position, the Valsalva maneuver or jugular compression may induce or exacerbate proptosis in patients with orbital venous anomalies or infants with orbital capillary hemangiomas. Pulsations They are caused either by arteriovenous communication or a defect in the orbital roof. In the former, pulsation may be associated with the bruit depending on the size of the communication. In the later, pulsation is transmitted from the brain by the CSF and there is no associated bruit. Mild pulsation is best detected on the slit lamp, particularly by applanation tonometry. A bruit is a sign found with the large carotid cavernous fistula. It is best heard with the bell of a stethoscope and is lessened or abolished by gently compressing the ipsilateral lateral carotid artery in the neck. Now, very important clinical feature is ophthalmoplegia, which is defective ocular motility, and it is very common in orbital disease. Causes include an orbital mass, restrictive myopathy, for example, thyroid eye disease, orbital myositis, tethering of muscles or tissue after orbital wall fracture, ocular motor nerve involvement associated with lesions in the cavernous sinus, orbital fissures or posterior orbit, for example, carotid cavernous fistula, Tolosa-Hunt syndrome, malignant lacrimal gland tumors. The following tests may be used to differentiate a restrictive form: neurological motility defect, which is, for example, forced duction test. Under topical anesthesia, the insertion of a muscle in an involved eye is grasped with forceps and the globe rotated in direction of reduced motility. Checked movement of globe indicates a restrictive problem. No resistance will be encountered with a neurological lesion. Then differential intraocular pressure test uh, involves less discomfort than post-duction test and an objective rather than subjective endpoint. The IOP is measured in the primary position of the gaze, and then when the patient is attempting to look in the direction of limited mobility, an increase of 6 mm of mercury or more denotes resistance transmitted to the globe by muscle restriction, which is called the Brevy sign. Saccadic eye movements in neurological lesions are reduced in velocity, while restrictive defects manifest normal saccadic velocity with sudden halting of ocular movement. We need to check movements in all 9 directions as it is seen in the picture. The next important clinical feature can be seen on fundus examination and most importantly is the optic disc swelling, which may be the initial feature of compressive optic neuropathy. As it is seen in this picture, you can see optic disc swelling here. Then it is optic atrophy, which may be preceded by swelling and is a feature of severe compressive optic neuropathy. Important causes include thyroid eye disease and optic nerve tumors. As it is seen in the picture here, you can see the disc is completely white and atrophic. Optociliary collaterals consist of enlarged pre-existing peripapillary capillaries that divert blood from the central retinal venous circulation to peripapillary choroidal circulation when there is obstruction of the normal drainage channels. On ophthalmoscopy, the vessels appear as large tortuous channels, most frequently sighted temporally, which disappear as at the disc margin. You can see it in the following picture. The disc seems enlarged as well, and vessels are engorged. The collaterals may be associated with any orbital or optic nerve tumor that compresses the intraorbital optic nerve and impairs blood flow through the central retinal vein. The most common tumor associated with shunts is an optic nerve sheath meningioma, but they may also occur with optic nerve glioma, central retinal vein occlusion, idiopathic intracranial hypertension, and glaucoma. Then there are choroidal folds, which may occur in a wide variety of orbital lesions, although tending to be more common with greater amounts of proptosis and anteriorly located tumors. In some cases, their presence can precede the onset of proptosis. Now, coming towards investigations in cases of orbital pathology, the first one is computed tomography or CT, which is useful for depicting bony structures and the location and size of space-occupying lesions. It is of particular value in patients with orbital trauma because it can detect small fractures, foreign bodies, blood herniation of extracellular muscles, and emphysema. It is, however, unable to distinguish different pathological soft tissue masses that are radiologically isodense. Confirmation of an orbital abscess in cellulitis is relatively common indication. After that, MRI, which is magnetic resonance imaging, can demonstrate orbital apex lesions and intracranial extension of orbital tumors and is useful for imaging orbital inflammatory disease. Serial short T1 inversion recovery stir scans are very valuable in assessing inflammatory activity in thyroid eye disease. After that, plain X-rays are little used except for the initial diagnosis of traumatic bony injury. Then ultrasonography can provide useful information, particularly with high-grade apparatus and an experienced operator, but does not image the orbital apex well. In the end, fine needle biopsy is sometimes performed, particularly in suspected neoplastic cases. Potential problems include hemorrhage and ocular penetration. The most common tumor associated with optociliary shunt vessels on the disc is optic nerve sheath meningioma, and that needs to be remembered. So with this, we are concluding this topic. If you like it, please click on the like button and subscribe to the channel. Thank you all.